Hello, thank you for joining us. My name is David Simmons, and I'm a director of the Canadian Club of Toronto. As Canadians do their part by staying home, medical staff are in hospitals, care homes, and other care centers round the clock, fighting the virus and providing comfort to those who are afflicted. That's why today, the Canadian Club's gathered a panel of experts to discuss how hospitals have endured during this unprecedented health crisis, how teams are working together to help us stay safe and stay healthy, and how the successes and challenges that they're seeing in their institutions across the country will teach us lessons as we enter the fourth month of the COVID-19 pandemic here in Canada. Before we dive into today's topic, here's some information about how you can participate. Click here to watch the stream button if your internet connection is slow. The video quality may decrease, but the audio quality will remain strong. Once you click the questions tab, you can enter your questions in the window and they'll be sent to the moderator. The request help button located at the top right of the page is there for technical support. Today, I want to thank our event sponsor, McKesson Canada. We're grateful for their continued support. Let me introduce our panelists. Dr. Susan Abbey is psychiatrist in chief at the Center for Mental Health at the University Health Network. Dr. Andrew Baker is the chief of the Department of Critical Care for St. Michael's and also serves as the incident command for Ontario's Critical Care COVID Command Center. Dr. Howard Evans is the emergency physician and chief medical strategy officer for Sinai Health System. And Taggar is the executive vice president and chief nursing officer, chief nursing and health professions executive at Sunnybrook Health Sciences. And today's moderator is André, Picard, health columnist for the Globe and Mail. One of our club's traditions that has not changed in this virtual world is that we make a toast to our country. Usually it's done in person by raising a glass. So I'd ask each of you to join me virtually as we nod to the screen and toast Canada. To Canada.
Canada.
André, I'll turn the podium over to you.
Thank you, David. It was a pleasure to be here today. We have in Canada almost, we're closing in on 90,000 COVID-19 cases, 6,800 deaths. About a third of all those, 30,000 cases are in Ontario and 2,200 deaths. Today, we want to focus on the reaction of hospitals. How have hospitals done with this unprecedented pandemic? I'm going to ask a few questions of our panelists, our esteemed panelists, and then I'm going to incorporate questions from our audience. We don't have a live microphone like we would at a Canadian club, but I do have my phone at the ready and your questions will be rolling in. So I want to start with a very general overall question. I want to know how hospitals, Ontario hospitals are coping. So I thought I'd start with you, Rue. You are an operations person. You have that big picture view. How are we doing overall?
Thanks, André. I would say that we're doing quite well. And I would say primarily it's because we've had time to get ready. And through that time, we've been able to organize and coordinate ourselves as a group of hospitals. And we focused on three primary areas. We focused on creating capacity for incoming COVID patients. We focused on securing our supply chain in terms of supplies and equipment. And we focused on our people in terms of ensuring that we're putting in the appropriate supports in supporting our staff and caring for COVID patients, as well as focusing on our staff wellness or their well-being.
Now, hospitals seem to have been exceptionally prepared for this. Is it because of what happened with SARS a while ago? Did it make us more ready, Rue?
I would say yes, we have learned quite a bit from SARS. And many of us haven't forgotten some of those experiences. And we also carry some scars related to SARS. People would say that as a result of SARS, our healthcare workers have a lot of residual concerns related to their own personal safety. And I would also say that, people would also say as a result of SARS, the system wasn't quite as ready during SARS. And therefore, we spent a lot of time and a lot of concentrated efforts to ensure that we were prepared in the best possible way this time around.
Now, Andrew, you're on the front lines. You're also at the command center daily. What's your view of how we're doing overall, hospital-wise?
Thanks. Well, I think today we're doing exceptionally well. Like Ruth says, I think people are adjusting to the use of PPE every day, to the change in the visitors. That we really like to have visitors, and that's restricted now. But I also think there's a tremendous sense of team awareness, and that's really been strengthened, not only within a hospital, but across the province, especially in critical care, which I've been involved in. Don't forget, André, that it is less than 2 months when, we were in the middle of a story. We're not at the end of the story, but the trouble with being in the middle is you don't know how it's going to unfold. Less than 2 months ago, in critical care, we believed that we were going to see demand outstrip our ability to supply life-saving ventilators and life-saving ICU beds. That's a very frightening place to be. And we also believed at the same time that we would run out of PPE. And so I think the critical care community across the province is incredibly resilient to be where it is today, which is feeling cohesive, gathering strength, and getting ready for the next phases.
Because we saw some horror stories in Italy and New York. It must have frightened people in critical care. Are you relieved now, or is it too early to be relieved?
I think it was tremendously sobering. I think there was genuine fear and a genuine sort of sense that this could really get beyond us. And it really sharpened the mind, as they say, for us to come together. And I think there was a sense of relief that through a number of efforts, as Rue mentioned, creating capacity, focusing on PPE conservation, creating a system, an organized system, huge. And then, of course, what the people of Ontario did through physical distancing and flattening that curve came just in time before we exceeded our capacity. So relief, from that sort of looking into the chasm, yes. But I think that nobody's prepared to say to let down their guard.
Okay. Now, Howard, you're in a big emergency room. We know our emergency rooms, were forever talking about them being overflowing and packed. They're eerily quiet now. How have you coped in the emergency room?
Well, everything that's been said so far applies to the emergency experience. And you've written yourself, André, in the past about Canadian emergency departments during the peak of flu season, where we become overwhelmed with patients waiting for beds who have pneumonia, who are coughing and often maybe spreading the virus, and we become overwhelmed. We were also, as Andrew said, anxious in the emergency medicine community at the beginning of March because of what we'd seen and heard in other jurisdictions. And so among the things that have made it a much different experience for us in Ontario, our hospitals, as Ruth said, created capacity, which does not generally happen in flu season. And as a result, patients were cleared up to their inpatient units as soon as they were admitted. The data on that is quite remarkable, and hallway medicine has pretty much disappeared from our emergency departments. We had adequate PPE thus far. The community, because of the anxiety and fear component, really pulled together. And within our hospitals, but even between emergency departments, even online, a great deal of information sharing and practicing simulations, et cetera, went on so that everyone was really primed and ready to go. And the last thing is the public helped, not just because of their staying home and flattening the curve. They stayed away from emergency departments and avoided getting our waiting rooms crowded. And to some extent, that's been a good thing. But I have to say, we also know of cases in every emergency department of people who've delayed coming to see us who should not have delayed and have missed windows of opportunity to get them treated. And so people should know that the emergency departments are indeed safe. And if you think you have an emergency, you're not going to catch COVID in the emergency department. It's safer than Loblaws or any grocery store. And if you have chest pain, shortness of breath, if you're feeling faint, have an unexplained fever, we would like to see you.
Because you've had kind of the opposite problem of other parts of the system, people having heart attacks and not wanting to go see you. That we've read some frightening stories about that too.
Exactly. Missed opportunities with heart attacks, with strokes, people presenting when their appendicitis has already progressed to burst where it's more complicated. So yeah, we don't want people to delay. If you do believe you have a true emergency, we'd like to see you.
Now, I'm going to come back to you later and ask you if hallway medicine's done forever, but we're going to hold on, keep people on the edge of their seats for the answer to that one. First, I want to go to Susan. Susan, your specialty is mental health, and we can just imagine the mental health impact on healthcare workers from something like this. Can you tell us a bit about that? How are they dealing with it? What do you see?
The mental health impact has been extraordinary, and as I think one of the real important things that has happened in Ontario has been people coming together to address that. So I think most hospitals have formed committees and groups. I sort of joke that I think most of the mental health community dealt with our fear and anxiety by making resources for other people's fear and anxiety. Certainly in sort of early March, we had people coming forward, particularly physicians and nurses who had well-controlled, had been not symptom-free from depression and anxiety for years, and the stress of watching what was happening in Italy and Spain and New York led them to have relapses. But really what I've been most surprised by is how resilient people have been. They have been incredibly resilient. I think there have been some added stresses for people who went through SARS, although it's also quite interesting because in contrast to SARS, I felt scared when I was in the hospital with SARS. I actually probably feel calmer in the hospital than I do anywhere else because I feel like our environmental teams have done such an incredible job in cleaning and keeping things done, and our hospital screeners and all of those things have been helpful. I think now what we start to see is some real fatigue coming in because people have been hard at this flat out for 8 weeks. And then there are a range of unintended things that I had not thought of when I was initially planning. For a number of our surgical colleagues and people who do interventional procedures, it's been very challenging. They're not able to do them. They have all this time on their hands. They can't make their mortgage payments. They're, really worried about things. It's been very challenging for a lot of them too. Understandably, patients are phoning up and asking when they can have their procedures. And, I don't know what today's number would be. A couple of weeks ago, we were 50,000 procedures behind in the province. So there are all these people in managing the wait list. So, there are many stresses, but overall, I think people have come together. I felt like a strong team, have been resilient and are really moving through.
And I want to ask that, healthcare workers have stressful jobs all the time without a pandemic. What's made the difference? What's the thing that's pushed them over the edge here?
Well, I think the hardest time for most people, I don't know whether my colleagues would agree, but was the first couple of weeks when all of the planning had been done. Everybody had, people were working 80, 90, 100-hour weeks to get the planning done. The planning was done, and as my grandmother would say, we're all dressed up and ready to go, and then there was nobody coming. All the elective cases had been canceled, the transplants, the big procedures. So the ICUs were empty. You could have gone bowling and emerge. People are waiting for things to happen. I think that was a very hard time. But then, once it started, the reality is that our intensivist colleagues, our emerge colleagues, they deal with infectious people all the time. They know how to protect themselves. But it was when there was all of the churn going on around, we're going to have PPE. I think the other thing that's been hard and that I would mention is that this is a new disease, and so we haven't had solid, clear information and certainty about it, and the way in which the story has evolved and what kind of PPE people should be using has evolved, and all of those things have been incredibly stressful for particularly I think for the frontline people. I think many of the people on this panel are at tables where they hear all of the discussion and they understand that people truly are making the best evidence-informed decision at the time. But I think often out on the front line it can look differently.
Great, Rue, I see you wanted to jump in there.
Yeah, I mean, I would just add, based on my discussions with staff, the main questions that I hear staff ask the most about are questions related to their own personal safety. And so this is a new dynamic for our staff, although there's we definitely have had staff work in high-risk areas before, but the degree to which their own personal safety is perceived as a risk to them is really heightened now during COVID. And so I hear quite often staff feeling conflicted about their commitments to their patients and meeting their obligations towards their patients, and asking themselves their own internal questions around, is this really worth it for me? What's the risk to myself in doing this job right now and caring for COVID patients, and the risk to my families? And you've probably, many of us have heard, and we've got staff at Sunnybrook who are in this situation where they've made their own personal decisions not to stay at home while they're caring for COVID patients, and they're making provisions in terms of staying in hotels or away from their families in an effort to mitigate the risk of exposure to their families. So that's quite the internal personal conflict, I think, is quite significant for many of our staff right now.
And do you think, is this going to change our perception of safety in hospitals forever? We keep talking about this new normal. Are we going to think differently about PPE all the time now? Rue,
I mean, I defer to my clinical colleagues. I would probably argue yes. I think there's a significant heightened awareness around the importance of PPE, how it's being used. But there's also new dynamics related to PPE, which I don't think staff historically have thought as much about, and that is the allocation of masks, for example. In the past, staff had always any access to any of those supplies. They still do, but we're careful. We allocate supplies in a controlled way more so than ever. That's a new dimension. That's a new dynamic for our staff. So I think staff are viewing PPE and the use of equipment and supplies and access to that in a very different way.
Andrew, maybe you could build on that. I'm interested in, what's this new normal going to look like? I've been around long enough that I remember when AIDS came along and it brought along universal precautions. Are we going to a new level of universal precautions now because of COVID?
Yes. I think you're absolutely right. I was around when AIDS came in before it was defined, and as it were, and it was a significant change. At first, we were all very worried, and then it became natural. And in fact, when we look back, why would we ever have exposed ourselves to blood on our hands and so on, like we did, by the way? It was shocking what we did in the 80s in terms before we were aware of AIDS. And I think, in fact, if you look carefully at some of our policies, that some of intubations for fever of unknown origin in people with respiratory symptoms, did point to the use of aerosol PPE, airborne PPE. And so I think this is a huge wake-up call, as Rue says, one, for the stewardship of our resources. And two, just like we do in public now, we sort of are a little bit shocked when people come close to us, which is really ironic. In the space of 2 months, if somebody stands too close to you now, you're sort of aware of it. And I think in a similar sort of way, we're very aware now of all the little things that we took for granted in hospitals. And I think a big one, for example, is the infrastructure and the 4-bed rooms that we have. What does that mean? So many movements of people, elevators, so on and so on. But certainly to get to the point, in ICU now, I think there will be a new pattern of awareness, stewardship of resources, and then caution around all the procedures which create aerosol or droplets.
And so nobody's going to do an intubation without an N95 mask anymore? Well,
I'm guessing that's going to be the case, and which is, over my time in critical care, is a absolute shocking evolution in time. I won't tell you what we did when I started as a student.
I know I used to get invited in to watch surgeries just in my street clothes, and that wasn't that long ago, it seems to me. But yeah, things have changed.
Oh, yeah.
Now, Howard, I want to come back to the ER. What's the new normal in ER going to be? Is it we're never going to wait anymore because that's going to keep us safer? Is that a dream, or what's going to happen in the ER?
So a few things that I think will be changes for the positive. I don't think it's going to stay the way it is now. It didn't during SARS, but it didn't go back to what it was before. Just as we increased our baseline handling of blood and bodily fluids after HIV came along, our knowledge and baseline proficiency with respiratory contact precautions improved after SARS, and it'll improve even further after this. Virtual care, I think, is here to stay as a much bigger option in the healthcare system. And we're even looking at a number of emergency departments around Ontario have been very innovative and have started offering their own virtual care options where you can contact an emergency physician and find out if you need to come to the emergency department. And if you are told that you should, then the department is already going to have a decent clinical note by a trusted colleague when you arrive. And I'd like to see that spread more. But unfortunately, I don't think we're going to see as short waiting times. Last night at my provincial regular meeting, we started our first discussion about flu season this fall. And it's a bit of a daunting prospect when we talk about capacity in hospitals. We're going to cut back almost certainly on our use of 4-bedded rooms and possibly even 3-bedded rooms, which will reduce capacity. We have to get surgical procedures going again sometime soon. And we're going to have an overlapping respiratory infection season with flu and other seasonal viruses layered on top of COVID. It's going to be very challenging, and we need to start thinking about our vaccination program for the fall. We need lots of vaccine. We need to get needles in arms early this year. And we have to start talking about capacity so that we don't go back to a very crowded, dangerous emergency department.
I was reading yesterday that 60% of procedures in the last month have been virtual in Canada. Really dramatic change. But I couldn't imagine the ER doing virtual procedures. How can you do my stitches if I'm on the phone or on my computer?
You know, family and friends will often call me and say, should we go to the emergency department? Does this need sutures? And I say, text me a picture of the wound. And often I say, nah, you're fine. Clean it off and put a Band-Aid on it. Well, now people, again, this is a few select emergency departments that have already started this, but we're going to look at what public policy requirements there are to make this facilitated much more broadly. And I think compared to calling a telehealth nurse, for instance, who doesn't have emergency skills and is working from an algorithm, to actually have a skilled emergency physician with video who is actually a colleague of the people who will see you if you're told to come in. And it may also help the safety. People may not delay if they hear from an emergency physician, I want to see you now with your chest pain. Hopefully you won't delay. So I think it could be a huge value added.
Great. And I'm going to come back to you about the fall because people are interested in this second wave business, but we'll get back to that. Susan, I want to ask you, we have a really intriguing question that's come in among our many questions that are flowing in. Someone is asking, you talk to a lot of health professionals. Someone is asking, what do health professionals need from Canadians now? What's the best thing we can do for them? Is banging the pots and pans enough? What can we do practically to help you out?
I love the banging the pots and pans, although usually I don't get home early enough to hear them being banged. So I think the biggest thing people can do is to wear a mask. You know, I think people now the science says we need to wear masks when we're out and about. I think continuing as hard as it is for all of us with the physical distancing is really important. I think those are the two things that really warm my heart when I see somebody with a mask.
So there's no magic bullet. The simple stuff is what is most important to everyone.
Yeah, I think so. I don't know what, I see Howard waving his hand.
Oh, yeah, jump in there, Howard.
Oh, the one thing I wanted to mention about the new normal for healthcare workers and for Canadians in general, hopefully we've seen a change forever in the attitude towards working sick. It's usually a badge of honor not to let your colleagues down and to show up at work with a runny nose or a cough. And you can't do that now. You shouldn't do that now, no matter what your job is, unless you're working in your bedroom alone. And I think that's something that people can do for each other right now is if you don't feel well, stay home.
Now, Rue, you oversee a lot of nurses. I want to ask you that question. What can Canadians do to show their support for those frontline nurses, PSWs, the people doing the heavy lifting, sometimes literally?
Yeah, I mean, I would just add, I would say the societal expressions of gratitude are really important. And for the staff to know that the community is behind them and they support and appreciate the work that our healthcare workers are doing, I think goes a very long way. And so I would say mostly it's understanding that, I mean, society is expressing their appreciation to our healthcare workers, and I think that goes a long way.
Great. Now, Andrew, we're focusing today on hospitals, and mostly we're talking about successes. Hospitals have done remarkably well, but why, in contrast, have long-term care facilities been a disaster? Why do we have this horror show that's unfolding in long-term care facilities?
Well, just to be clear, I think I'm at the other end of the acuity spectrum. I work in ICUs. And so I sort of know what you and I think Rue and actually Howard may be better poised to answer that, to tell you the truth.
Okay, well, I'll let you off the hook for now then.
I just don't want to speak where there's people who know more about it than me in the same room. Okay.
I just had a sense there's a lot of the overlap in that clientele. So
I think there are, and I think we're seeing in ICU patients who come from long-term care. And I think the message is just carrying on from what Rue said, and to connect these two questions, I would like to say two important things in addition to what Rue said. And that is that I think we've had, people think that the people who are dying are elderly, and that is true. But I think you need to remember that a large number of the elderly who have COVID have survived, probably more than half. And so I'm very concerned about a type of ageism, that this is just a disease which is going to affect the elderly. First of all, it has affected many people under the age of 60, under the age of 50, and many of those people have died. And many of the people over 60 have survived. And so I'm very concerned about that, because we are not ageist in healthcare. We are about people's physiology, and there's many young people who are out of shape and many older people who are in great shape. And so that's a very important notion in my mind. And
really important point, but it's also important that we focus a lot on the mortality, but a lot of people have, you see them and they're going to go home with consequences that are going to be with them forever too, right?
Absolutely. And we're starting to see this, and Susan may know more about this, but there is a real group of patients who remain in the ICU, some of them now for many, many weeks, and who look to me like they are going to need long-term ventilation. And some of them who've come off the ventilator look like they have sort of long-term impact on the respiratory function.
Wow.
So the other thing that I was going to mention that related to what people can do, and that is to just like not making the mental error of thinking that this is an elderly person disease and not to worry. I think it's also that we shouldn't sit around and wait for technology to save us, just like some people do within the environment. Technology may not save us. I don't think we should wait for a vaccine only. I think if there are public health measures, we need to do those. And I think that makes a big difference to healthcare workers. And I think that when ICU doctors are aware of these issues and then see congregations literally and figuratively across North America, it's hard not to take that personally.
Well, you'll be happy to know that as we speak, they're drawing circles in that Trinity Bellwood Park. So hopefully things will be better this weekend in Toronto. Now, Rue, I want to come back to you with that. I think it's an important question. Why have hospitals done so well and long-term care facilities have really struggled, and it's cost people their lives? What's the difference?
Yeah, I mean, I think it's multidimensional. When I think about it, first of all, I just want to say it's quite tragic to see what's happened in the long-term care sector. And I want to acknowledge the hard work of the workers in that sector, and they're doing everything possible that they can within the system. That isn't ideal, to be frank, in long-term care. So there are differences from my vantage point in terms of access to expertise. Long-term care hasn't necessarily had the advantages that we've had in hospitals in terms of infection prevention and control experts. And therefore, hospitals are now helping out with providing that expertise. So I think practices, structures, and supports, infrastructure related to effective infection prevention and control measures weren't necessarily at its optimum level in long-term care homes. So I think infrastructure has been a real challenge for them over time, and it's been eroding over a number of years. So I think that's led to a system in long-term care that is suboptimal in my mind.
Howard, wondered if you had anything to add about the real gap between hospitals and long-term care outcomes.
Well, there will be inquests writing about this for years to come, but certainly we know some of the things. I think Rue's correct about leadership and competence around infection prevention and control. Staff culture also around this, and not seeing the same kind of community of practice where people reach out to each other to answer their questions and practice donning and doffing and all the other skills that they need. But if I had to put my finger on one thing, it's who's responsible for safety in long-term care. And if you don't have one throat to choke, you're in trouble. And where either in an individual home or in a community where somebody took responsibility, outcomes were much better, and it's been reported in the Globe and Mail. But I know personally, the example I like to give is because he's an emergency physician, and I'm proud of emergency physicians who do well. But Kieran Moore in the Kingston area is also the medical officer of health for that area. Jumped on this problem very early on, and responsible for 27 long-term care homes, whether they're private or publicly funded, and or operated, and had not one positive case in 27 facilities. That's more than just good luck. And I think that sort of clarity about personal accountability needs to be replicated.
Yeah, so hospitals are a system. They have a chain of command and someone's responsible. Very important points. Now, Susan, we're getting bombarded with questions. People want to know what's next, the second wave, how do we prepare? So I wanted you to start with, how are workers preparing with this notion that we know, we're starting to realize it's going to be with us a long time? Mentally, how do you prepare for this, that COVID's here to stay and it could get worse?
To me, that's sort of the biggest challenge that we're facing right now. And, I think you always try to skate to where you think the puck's going to be. So in the mental health community, we're trying to wrap our heads around this. Just on an individual level, I've got a dear friend whose comment at the end of every day is, we're one day closer to things being better. So, I think that's important, but it's very challenging because, we live in a society where you can go to Tim Hortons, I was going to say, go to Starbucks and, up until now, get your latte at exactly the temperature degree you wanted with exactly the mix of milk and how many shots of espresso and everything. People are very used to being in control, and we are not in control with this one. We're in control with wearing our masks and not doing stupid things. But this is really challenging. We're going to have to find ways of finding meaning and purpose in everyday life, of maintaining our social connections. So lots of folks are doing online dinners, lunches, brunches, cocktail parties, dance parties, with Zoom technology, giving help to other people. So a number of my friends have kind of got a list of people that they call and check in on regularly. But I think it's very challenging, very challenging.
And Andrew, how do hospitals prepare for, we're not sure what's coming next, this second wave may come in the fall. How do you prepare for that?
Well, there's a lot of things being done in hospitals and very quickly, and it's almost as though we are rethinking almost every corner of hospital care to the point that we have to control ourselves to really focus. But in critical care, for example, we've tightened up our thinking for across the province being a system of critical care. And so we're really connecting better than ever around having patients get to the right critical care unit at the right time for the right thing. I think subtly, I think it's a good thing because I think we're asking ourselves and asking patients and families to think about their advanced directives and whether critical care is right for them for non-COVID disease, which is actually a good thing and something that many of us have avoided. And so we're thinking more carefully about the stewardship of those resources. I think we're training ourselves better for PPE, and I think where I talked about fear before, there is a real sense of camaraderie and confidence and actually joy that when you have the right PPE and you're trained up in a team, it's actually a lot of fun. You know, if you know what you're doing and you're confident and you got the right team, people in healthcare are there because they like it and they like high acuity things. And so there's that sort of thing. I think we're looking at infrastructure and how to sort of find the single rooms and make sure that the ventilation is right and all that sort of thing. And I think we're taking a very close look at getting real value out of the system, coordination through hospitals. By value, I mean making the best use of the limited resources we will have. If for no other reason than we're going to be trying to do more with the same or more with potentially less.
I think that's the first time in a few months of talking about COVID-19 I've heard the word fun. So
terrible, isn't it? But people do like to come to work when they're trained and have the equipment. That's and
when they know they're having an impact. You're definitely having an impact these days. Now, Howard, I want you to look forward to the fall, your crystal ball. A lot of people fear this two respiratory illnesses at once, COVID-19 and the flu. Are you dreading the fall?
So from a frontal lobe perspective, I'm focused on planning and preparing. And emotionally, I'm staying rooted in today.
Is it something we should worry about? Well, let me ask it another way. Look into your crystal ball and tell me what's going to happen in the fall. Is the second wave going to be worse? Is it going to be okay? What?
So, first of all, anybody who predicts the future in the real estate market, the stock market, or in healthcare should be viewed with some suspicion. Every previous epidemic we can look to as an example has had a second wave phenomena, and there's no reason why this one shouldn't. And so we're going to have to ask ourselves some very difficult questions if infections spike in the fall, and if hospital capacity is stressed. Do we close schools again for a few weeks, for instance? What other measures would we take? So I'm a little anxious about the fall. I think we got off, again, with the tragedy of long-term care notwithstanding, as hospitals and as society, we got off a little bit easy this time, especially the rest of Canada other than Toronto and Montreal. So I think it'll be possibly another major challenge in the fall. We may not get off quite so easily. We've learned a lot. We've bought a lot of time. Hopefully, we continue to use that time to secure our supply chains, build our stockpiles, get nimble with our strategies so that when we see trouble start to arise, we don't have to make it up. We already know how we're going to respond.
I think you sparked a few heart attacks there when you said to parents, we may close schools again, but hopefully you'll be able to take care of those heart attacks in the ER. Now, Rue, I want to turn to you. We have lots of questions about, all these surgeries have been delayed and canceled. How are we going to catch up, or can we catch up? Or people are asking.
Yeah, so it is a significant worry. If you were to ask me what's on the forefront of my mind right now, it's that. And so while I think we're ready as we can be in terms of dealing with an influx of COVID patients, the question is to what detriment? And I would say that, we've had 6 weeks of patients who have been waiting for their surgeries, and we've got a developing backlog. And so the challenge for us moving forward, above and beyond what everybody else has already said, is how are we going to juggle the needs of addressing, patients who have been waiting and they're now becoming sicker and their situation is becoming more urgent, and ensure that we are able to address that with the needs of COVID patients if we have a second wave. And that is probably really going to be our biggest challenge moving forward from an operational perspective, for sure. So the way in which hospitals are approaching that to date is we've been having lengthy conversations around how we address patients that are waiting. And we are slowly, in a very measured way, in an incremental way, starting to increase our surgical procedures and our clinical activity in our ambulatory settings, in our clinics, to start addressing those patients that have been waiting and that are of highest risk. I expect over time, though, if we start to get more COVID patients, we may have to adjust our volumes of those patients that have scheduled activity with incoming COVID patients. So it is going to be a significant balancing act. And I've never seen anything like this before in the history of my time in healthcare, around having to juggle those two principles, which are significant principles. Patients are waiting and they're getting sicker. And also at the same time, we have to be prepared and ready to deal with sick COVID patients.
A lot of uncharted territory for everyone in this one. So we only have a couple of minutes left. My tradition is I always like to end a panel on an up note, something uplifting. And a few people of our people who have tuned in have asked us this. They want to hear them. What's the most uplifting thing that's happened during this epidemic for you? Because we have a lot of depressing news. What's the most uplifting thing that you've heard? Each of you a quick story, and I'll start with Susan.
Ooh. I was going to say, you might not think this is uplifting, but I think the other thing nobody's really talked about, but there's been a terrible trouble around grief because all of the rituals in the healthcare system to help healthcare workers work with grief aren't there. And so one of our spiritual care consultants has developed a very beautiful online memorial service, and a friend of his wrote original music for it, and people donated some artwork with it, and it's deeply touching and it has been quite soothing and helpful to some people.
Yeah, that's lovely. Finding new ways to grieve. We have to adapt. Great. Andrew, what's been the most uplifting or hopeful thing that's happened for you?
Well, two things which are the flip side of the same coin. I have seen such tremendous acts of selflessness and kindness in the face of some real tragedies I've seen in the ICU, just heart-wrenching tragedies, and people really rising to the occasion. And I really like healthcare workers. I must say, I just think they're a tremendous group, and the camaraderie that you feel is astounding. And I think life has slowed down for all of us in healthcare because we just go home. There's nowhere else to go. And so I think everyone has taken time to just be calmer and kinder. And I see that every day.
Yeah, kindness has definitely become a really important thing in our daily lives with all this stress.
Yes, it has. Yeah.
Howard, you always have a good uplifting story for us.
If I could take two quick ones. One is the speed of information, new knowledge generation and sharing. There's a lot of noise, but in there's a signal that's really unbelievable in terms of the pace of research innovation and the generosity with which it's shared. And then the bravery, besides the kindness, my colleagues, older colleagues with illnesses who just could not stay away. We even had a nurse of ours who was working in Germany. She hadn't been here in 3 years. They wouldn't license her, and she flew home just to join us back on the front lines of the emergency department because she said there can't be a pandemic without me being there nursing with my colleagues, and spent 2 months with us. And that kind of individual commitment has really meant a lot to all of us.
Yeah, we've really seen the dedication of healthcare workers, something that is a daily reality, but the public's seeing it now.
Our cleaning staff, everybody in the building, it's really amazing.
And Rue, give us an uplifting story, a hopeful story to send us home.
Yeah, I mean, I would just add to the theme about the staff. I've been terribly inspired by the staff to the point where it brings tears to my eyes. So a very quick story. When we were creating our COVID units, we actually put a call out to our staff and asked them to volunteer. And honestly, I didn't think we'd get any volunteers. And we have 80% of all of our staff have volunteered to work on those units. So staff stepped up in a way in which I never would have imagined. And it's been really, really inspiring to me.
Oh, that's a lovely note to end on. It makes me want to bang a pot, but I don't have any in my office. But I'll do it virtually if I can. Now, I want to thank everyone very quickly, but I'm going to turn it back over to David Simons for some final thank yous. And thank you, everyone, for joining us online. It was a different kind of Canadian club, but very interesting. Thank you all for participating in the discussion.
And thank you, André, for moderating so well. I know many of us trust you as a voice in healthcare and health reporting, and you didn't let us down today. That time went really quickly because it was an engaging conversation. I heard a couple of things that I think are important to repeat as we close out the event. I heard that our emergency rooms continue to operate. They're open, and we ought to be comfortable and cognizant of the services that are being offered there. I heard that our hospitals are strong despite the pressure and the stress on our hospital system. Our healthcare workers are truly heroes, and they're doing their part. I also heard that self-care is an important tool in maintaining our healthcare system, and that we need to be responsible and accountable about how we navigate and operate over the next the next time horizon that's undefined, and that self-care is a key part of that. And one of the things that I heard that really jumped out at me, and I'm actually going to take it and I'm going to use it with my team and the organization that I work with, which is that we're one day closer. And we don't know closer to, but we're one day closer. So thank you to our panelists for joining us, for your insights, for your contribution, and for your continued care. I hope you can join the club next week or next Thursday on June 4th. We're going to have an expert panel on a discussion around Indigenous capitalism. If you're as intrigued as I am to know what that is, you'll tune in on June 4th to hear more. I'm going to thank McKesson Canada, and I'm going to be transparent. I'm thanking McKesson Canada for sponsoring, but I also work for McKesson Canada. So I want to thank the organization for financially supporting this event, but it's also a healthcare company that supports our workers on the front line. And I'll thank my colleagues across the country who are doing that work to support people represented by the leaders on the screen. We want to thank our AV supplier, Van Vulkenberg Communications and LiveMeeting.ca for making it possible for us to bring this content to you online. Thank you for joining us again. Thank you to our guests. Thank you for our panelists. Please stay healthy, practice self-care, and wash your hands. That's the end of today's event.